For our Grand Rounds project, we chose the novel,
Coronavirus!
also known as COVID-19. Our group members are Mariah Beam, Kylie Skolnick, Heather Hall, Claire Kimbrell, and Reagan Wingrove.
This is our case study. Susan, a 65-year-old female, had plans to go visit some friends at their neighborhood clubhouse for an afternoon of activities. However, on the morning of, she woke up with extreme fatigue, cough, headache, a sore throat, and congestion. Due to her children's concern, they advised Susan that she should go see her primary healthcare provider to see what may be causing her symptoms. Upon arrival at the doctor's office, Susan walks from her car to the entrance door of the building and has to stop in order to catch her breath. During the examination, Susan was asked by her physician of any recent history of travel or exposure to someone who may have contracted the new coronavirus. Although Susan had no history of travel herself, she did attend her granddaughter's graduation party 3 days ago, where one of her closest friends had recently just returned from a trip to New York. The physician proceeds to take Susan's vital signs, where they show a fever of 100.8 degrees Fahrenheit and an oxygen saturation level of 91%. Due to her signs and symptoms, the physician runs a strep, flu, and a rapid nasal swab COVID-19 test due to her age and increased risk. Susan's COVID-19 test comes back positive, and her physician advises her to treat her symptoms by medication or remedy of her choice, since there is currently no treatment or vaccination against the coronavirus. Upon Susan's medical diagnosis of COVID-19, her physician notifies her that she is to self-isolate for 10 days and needs to be fever-free for 48 hours before her isolation period should end. Susan's physician can tell that she is frustrated about the isolation precautions that are put into place and advises Susan to reach out to family members to remain in contact throughout this time period. However, her physician notifies her that in order to prevent the virus from spreading, that these precautions are necessary.
Pathophysiology of COVID-19. A receptor and an S protein interact to connect the virion to the host cell. The envelope spike glycoprotein of the COVID-19 virion attaches to its receptor. The viral and cellular membranes fuse together and the virion enters the host cell's cytosol. The viral RNA hacks the host cell's replication process, and the viral genome begins to replicate within the cell. After the synthesis of viral proteins, the proteins enter the cell's endoplasmic reticulum, where they develop into mature virions. Then the virions enter vesicles and fuse with the cell membrane, engaging in exocytosis. The viruses then enter the extracellular fluid and invade other host cells.
For assessment findings, a thorough patient history must be collected, and this will include asking the patient about cold and flu-related symptoms and onset of these subjective symptoms. These include fever or chills, cough, shortness of breath, difficulty breathing, fatigue, muscle or body aches, loss of taste or smell, sore throat, congestion, runny nose, nausea and vomiting, and diarrhea. Asking the patient about recent travel history. Recent travel could be a key factor to determining if a patient has been in a high-risk area of COVID. Asking the patient if they have been in close physical contact with anyone who is experiencing COVID symptoms. Asking the patient if they have been in close contact with anyone who has been tested for or tested positive for COVID. Asking the patient if they are currently waiting on the results of a COVID test. Asking the patient what chronic problems they have been diagnosed with. We have to know about respiratory and cardiac problems in the patient's history that could be possible underlying conditions that worsen COVID, such as history of asthma, ARDS, COPD, pneumonia, and recurring bronchitis.
Holistic assessment findings. Now we would assess the physical and physiological status of the patient. This includes a full set of vital signs. We would assess a temperature, and we would look for over 100.4 So we would assess temperature and look for a fever above 100.4 degrees Fahrenheit. We would then look at oxygen saturation. This varies with cases due to health histories such as respiratory or cardiac problems. And oxygen saturation below 92 to 95% would be alarming for this disease process. We would see an increased heart rate due to infection, and this would correlate with a decreased blood pressure. We would then look at respiratory rate. It is usually increased due to shortness of breath, making the patient work harder to breathe. This also varies with cases. If a patient has a low respiratory rate, then they could possibly be in distress or have a collapsed lung. We would then do a neurological assessment and see if the patient is alert and oriented ×4. We would then inspect the chest, do a full chest inspection. We would look for retractions, nasal flaring, rapid shallow breathing. We would then assess the skin, looking for warm or dry temperature. COVID patients are normally cool and clammy and diaphoretic. We would then also take all lung fields. On inspiration and expiration, we would listen for crackles, wheezing, stridors, etc.
The other categories for holistic assessment findings include psychological. The Maslow's hierarchy of needs is used to conceptualize their hospital stay and care plan. The needs include physiological, safety, loving, belonging, esteem, and self-actualization. Sociological. This is used to determine their family network. Notice the patient's response to their feelings about being in isolation and being separated from their family. Family is typically the biggest support system for a patient. Try to be aware and helpful whenever possible. Developmental. COVID can affect people of all ages, so using Erickson's stages of development is important to be aware of what developmental stage the patient is in as well as their cognitive function. COVID can affect these stages differently. For example, patients in the early adulthood intimacy versus isolation stage wouldn't be affected by the symptoms as bad. However, they may be more affected by the isolation aspects of COVID. Patients in the old age integrity versus despair stage would not have as much problems with being in isolation or having much social interaction, but they would be heavily affected by the symptoms of COVID. Spiritual. Ask the patient about their spiritual and religious practices to guide the care plan. The patient could have different responses how they want to be treated. For example, the patient can choose spiritual practices over life-saving measures because of their faith. Culture. Patients will have their own dietary and cultural preferences. Nurses need to be culturally aware. For example, patients have certain beliefs like no eye contact and personal space.
Assessment findings continued. Labs. COVID-19, flu, and strep tests would all be taken to determine which disease is causing respiratory problems. Blood work will be drawn to collect the following: complete blood count with differentials. With this, leukocytes, or white blood cells, would be looked at because it is a key indicator of COVID. Increased or decreased levels would indicate infection. Complete metabolic panel would show increased liver enzymes with COVID patients, and C-reactive proteins are also a marker for determining COVID patients with CMP. Elevated D-dimer, a clotting factor, will be seen with COVID patients. These levels correlate with the disease severity. Diagnostic tests. With the chest x-ray, ground glass opacity is seen in an x-ray where there is fluid in the lungs. CT scan is what will be done and observed after there are abnormal findings in the chest x-ray. An EKG will determine any heart rhythm abnormalities. This could be important to know for patients with a history of atrial fibrillation. If the EKG comes back with abnormalities, put the patient on a continuous heart monitor.
Medications and treatments. At the moment, there are no current treatments or vaccinations for COVID-19. The only available option is broad-spectrum antibiotics such as nucleoside analogs or HIV protease inhibitors that combat further infection until a specific antiviral is created. Remdesivir can be administered 200 milligrams intravenously on day 1, followed by 100 milligrams up to 10 days after. Researchers found that 500 milligrams chloroquine has a promising profile against the virus. World Health Organization has 2 candidate vaccines prepared, and they were in phase 1 of the clinical trial on March 26, 2020.
Family-oriented diagnosis. Those who are diagnosed with COVID-19 are advised to socially distance and isolate themselves from others to contain the spread of this extremely contagious disease. This can be somewhat difficult for families, especially those that live together. For our family-oriented diagnosis, we found that compromised coping methods relating to COVID-19 are evidenced by distorted communication, increased confusion, and reduced familial gathering time. Since this disease is so new and unknown, it is important to understand how it can affect a family structure. Interventions for this diagnosis include the promotion of family members wearing proper facial coverings to reduce the spread of the disease, not only to other family members, but to themselves to contain the disease. Collaboration between the family and the healthcare providers is imperative, for this disease is new and much of its being is unknown. The stronger the line of communication, the more informed the family is, which promotes healthy healing and understanding. Respecting the role of family members as remote caregivers must be done in order to obtain complete understanding of how to control and localize this disease.
Psychosocial diagnosis. Social isolation related to communicable disease as evidenced by isolation precaution. Patients diagnosed with COVID-19 must be held under strict isolation precautions for at least 10 days after testing positive and must be fever and symptom-free for at least 48 hours before ending isolation. We chose this diagnosis because being held in isolation for that long decreases interaction with loved ones and can affect the patient's mental well-being. Related factors that may be seen include depression, low self-esteem and worth, loneliness, and even changes in physical appearance such as weight loss or gain. A few interactions for this diagnosis include instilling coping mechanisms like encouraging the patient to use relaxation methods to cope, such as listening to music, reading, or spiritual practice if applicable. Another intervention would be to orient the patient to reality by asking questions related to person, place, and time. We do this because patients can start to get confused after being held in isolation for so long. Lastly, I would encourage the patient to be as active as possible in physical and social activities to promote self-esteem.
Spiritual diagnosis. Spirituality is an element in a patient's life that may be tainted when diagnosed with COVID-19. Patients are at risk for spiritual distress related to reduced interactions with the world, others, or a superior being as evidenced by lack of hope, meaning, and purpose in life. Anger towards a power greater than themselves is a common feeling that is expressed by those experiencing spiritual distress. This can be shown by any physical, emotional, or spiritual barrier. Since COVID-19 is such a new disease and new information is being uncovered about it every day, it is common for patients to express a lack of hope, meaning, and/or purpose in life due to the uncertainty of their new diagnosis. CDC guidelines strongly suggest isolating yourself from the rest of the world in order to control and reduce the spread of the disease, which can potentially leave patients feeling abandoned by others. Interventions for this diagnosis include observing individuals for cues that show difficulties in finding meaning, purpose, or hope in life related to social detachment. Also, monitoring and promoting supportive social interactions per CDC guidelines could reduce the risk for spiritual distress. Spiritual support needs to be offered to families and caregivers of those with COVID-19.
Sociocultural diagnosis. Deficient community health related to insufficient resources for problem solving as evidenced by no vaccine or treatments available. COVID-19 has deterred the health of many communities, and since there is no vaccine available or medication specifically for the treatment of COVID-19, the communities do not have the resources needed to fight the virus. Thus, it is reducing the health of communities. Also, there are limited resources to cleaning supplies such as soap and hand sanitizer, Lysol, Clorox wipes, etc. These are needed to help fight off the virus also. Interventions for this diagnosis include assessing the demographic variables that predict community mortality, such as the patient's age and where they are from, implementing community engagement techniques, and educating the patient about management of the disease, like encouraging hand hygiene, wearing a mask while in public, coughing and sneezing into a tissue or sleeve, and social distancing, etc.
COVID-19 is caused by the severe acute respiratory syndrome coronavirus 2, with its primary target being the respiratory tract, which can cause inflammation of the lungs and alveolar damage. Clinical indications of respiratory distress and damage include increased respiratory rates, decreased oxygen levels, chest discomfort, and increased oxygenation demands. Raising the head of the bed will help to promote effective breathing by maximizing inhalation with decreased amount of effort. Deep breathing and coughing exercises will help patients effectively clear their airways in order to maintain proper oxygen levels. If a patient's oxygen levels do not improve, supplemental oxygen can be supplied as ordered, which allows the lungs to get more oxygen than is available at normal room pressure.
Interprofessional team management. The primary healthcare provider is the one that diagnoses the patient and determines the plan of care. This is the medical doctor, doctor of osteoplastic medicine, or a mid-level provider such as a nurse practitioner or a physician's assistant. Nursing provides and coordinates care between the interprofessional team. The infectious disease specialist treats infections and is often referred by the primary care doctor. They are usually seen on a COVID-specific floor in a hospital. The pharmacist works with the doctor to determine the correct medication for the patient and answers patient questions about the medications. The respiratory therapist experts in diseases that affect the respiratory and provides respiratory management. Radiology does x-rays and CT scans and then sends results to the radiologist to be interpreted. Dietary management includes creating a patient-specific meal plan that provides a proper nutrition. The spiritual provider meets the patient's spiritual and/or religious needs.
These are our references.